Hello, friends. Welcome to Cardio Talks by Manipal EM Bypass, Kolkata. ACC 2026 in New Orleans has just wrapped up. We got some great insights, we got green signals, and we also got some red flags and red alerts. And we have trials which proved again that it's not always more is better in cardiac cath lab. So let's start with our breaks and red flags. Debopriyo. So we have got two trials on Impella, one in STEMI door to unload, and second in protected PCI, basis chip basis 3. So though both the trials gave us some insights which disappointed us. Do you feel it is disappointing? Can you give insights on these two trials?
So, first trial, the STEMI DTU trial, this was a trial which compared the upstream application of microaxial flow support devices in patients who presented within the first 1 to 6 hours after a AMI, and they compared with the normal standard of care revascularization. And what they showed in the long run was there was no difference in the outcomes when we unload the left ventricle before performing a primary PCI. And subsequently, what was also very glaring was the amount of bleeding complications in the microaxial flow support devices. It was to the tune of 30%. So, in summary, what they came up after this trial was there is no added advantage if we unload the ventricle in patients who are presenting early and patients who are not in cardiogenic shock. So, in one line, this trial was a negative trial, implying that Impella is a device which will help you in patients who are in cardiogenic shock, not otherwise.
Yeah, so absolutely it was not kind of disappointing for us. There was a school of thought which really were convinced that in STEMI opening the artery is the prime thing. As early as possible you have to open the artery. Unloading the heart, taking that time, and then going for revascularization may not be correct idea. But the second trial which said on Impella protected PCI chip BCS3, so that was you feel that was a disappointment?
I think the second trial was actually, we knew that there was nothing positive which will come out of the second trial. The CHIP BCIS3 trial divided patients into high risk subset. So they defined patients whose EF is less than 35%, multivessel PCI, syntax score of at least 38, age on the elderly side, complex calcified vessels, and they provided Impella in patients who had this category and compared with the standard of care, which is non-Impella assisted complex PCI. And what they saw was it was a non-inferior trial, in fact, a negative trial, which showed again that if we are choosing patients who are complex, Impella upfront does not actually decide the outcome of the patients in the 30-day or the 90-day.
Yeah, so kind of it challenged our results from Protect 2 and Protect 3, isn't it? So it's a bit of a kind of a thing which will take away, it's a good takeaway from ACC 2026, where we should not be going after Impella, especially in patients with a high risk score of intervention. I don't know where there are subset of patients which can be benefited. I think future studies can be more instrumental because we have some trials which are positive now. GBCS3 has given some,
Summarizing, sir, probably the takeaway after these two trials would be the only subset where Impella would be effective is patients who are in cardiogenic shock, who there is nothing to lose. I mean, comparing the amount of vascular complications, the amount of mortality in the previous trials, we all have come to a conclusion that Impel is only effective in cardiogenic shock, wherein the amount of complications will not negate the amount of advantage.
Yeah, absolutely. So there was a in STEMI door to unload, US patients, where the patients recruited from US had very less vascular complications, bleeding complications, but outside US patients who were enrolled had a lot of bleeding complications. So how we do it, the expertise and the risk which is involved with Impella injection is also not generalizable.
No.
So we have to pick our patients well. So with this little kind of negative sort of aura, let's look at the positive things which we have got. Green signals from ACC 2026, and we have got trial on left atrial appendage device, Champion AF, and we also have angiography based FFR. So Ashesh, can you describe? Can you tell us something about Champion AF? What you feel about that trial and the All Rise trial?
So in all these years, maybe more than a decade, we are quite habituated with the use of NOAC in patients with non-valvular atrial fibrillation to prevent stroke. So only 2 points I want to mention here is that adherence, the other is bleeding complication associated with it. So LAC, that is LA appendage closure, that is being considered in patients who are having contraindication to NOAC. But this time in Champion AF, they tried head-to-head LAG versus NOAC, who are actually NOAC eligible. And they tried to see whether the primary endpoint is differing or not. And interestingly, the LAG group, they did as good as the NOAC group.
Absolutely. So it's not now, in patients where we can't give NOAC, there is a solution from LAAC, but it can be seen as an alternative.
Yes.
But at the same time, we have two indication as of now for left atrial appendage closure devices in patients who have bleeding episodes. You feel that it can be shifted now in favor of LAAC, even in patients who are eligible for NOAC. Number one. Number two, your idea about two trials, Closer AF and Champion AF, coming almost simultaneously, one in TCT 2025 and one in ACC, simultaneously published more or less in NHA and JAC. So both with contradictory results. What could be the reason?
So in respect to the primary question, I would be skeptical. The reason is, if you look at the bleeding endpoints associated with the procedure aspect and post-procedure in patients in LAC, they did quite similar as compared to the NOAC. But post-procedure bleeding was far less. So this is too early to say whether LAC will be used as an alternative to NOAC at this point of time or not. The second thing, in Champion AF, the CHAD-S2 was 3.5 and the patients were not elderly. And just to mention, in Closure AF trial, they chose patients who are having much more higher bleeding risk, as well as the CHAD-S2 was around more than 5. So they are different.
Yeah, so I think when we look at, in a more granular fashion, we feel that the inclusion criteria, patients' average age was 79 years in Closer AF. So it was this group of patients, if you intervene, you expect a high periprocedural bleeding and all, and that's created a difference.
Yes.
So if we choose a patient like in 71 years was the average group in Champion AF, and I also feel since we are a center where we do LAC and we are the training center for left atrial appendage device, and all of our patients doing well except one patient who required pericardial drainage, and one patient had a pericardial effusion subsided on its own. Rest all patients were fine. So we coming from our experience, it's a device, a wonderful device if we choose our patients well, and if we do it in patients with 60s and 70s, not in 80s, where the patient will be free of anticoagulation for 15-20 years. You can appreciate. In between that time, patient will require some operation, some surgery, some bleeding episodes, and you are comfortable.
Yes.
Yeah. So, and now how about AI in angiography-based FFRs? Wires are out.
Yes. So this is an interesting. There's an introduction of AI in the FFR-based technology. So in this trial, All Rise trial, we have been using the FFR-based technology, wire-based technology for a very, very long time for the physiological assessment to decide whether to put a stent or not. But this time, angiography is good enough. So what they did, AI-based technology was used to predict the physiological assessment from only after the angiogram is being done. And that was compared with the wire-based FFR assessment. And interestingly, in both the groups, they did similar. So obviously, this is a high time we can introduce AI in the physiological
less
assessment.
Is better in cath lab.
Yeah.
So less is better in cath lab. More is always not good. That's what the final kind of conclusion from ACC 26, which we can draw. Just before we wrap up, one or two sentence lines from you on PITO, where do you feel that this intermediate category of pulmonary embolism patients, we can really choose what are the...
Sir, I think high PITO has shed enough light to choose patients of intermediate high-risk pulmonary embolism. And previously, we used to suggest them low-dose thrombolysis, and there was then ifs and buts whether to do or not to do. But then after this trial, the results are very much positive that if we do a catheter-driven thrombolysis, that is not systemic thrombolysis, the results are good.
Yes, because we are using less dose and more local. So it makes sense and logical now with evidence.
And no bleeding.
That intermediate risk also we can go after. Finally, a last word from Ashesh about have we gotten conclusion on when to intervene on coronary disease in severe aortic stenosis patients before TAVR or after TAVR or during TAVR?
So this remains always confusion whether to do it earlier or not. So this is an interesting trial that is called Pro-TAVI, where they have shown if you do PCI before TAVI, that group will do similar if you defer PCI after the TAVI is being performed. So that
so we have three trials, two in favor of waiting, and one that you can go ahead in Notion 3. So maybe Notion 3 can be outlier. In our practice also, we try to wait. Yes. We don't do coronary angiogram before TAVR. We do CT TAVR protocol, and we feel that see the coronary is there, and if the patient is not that symptomatic, then we can go ahead with TAVR, and then we can do the coronary intervention after that. So with this, we end here our first episode of Cardio Talks by Manipal EM Bypass Kolkata. Hope to see you all in our next episode. Thank you so much.